Hello, everybody. We'll be starting on time. My name is John Strauss, and I'm the founding director of MCPAP for Moms. And um, I'm happy to have you join today to our regular clinical conversation that takes place on the fourth Tuesday of every month. And um, today's topic is early psychosis symptoms, identification, and treatment. And this is actually really exciting for me to hear this because I can think back to many, many years ago when I was in primary care practice and a 14-year-old came in for her just a regular well child visit. And she mentioned that she was pretty anxious because she was when she rode the school bus in the morning, she um, she was really upset because people could read her what she was thinking. And she asked me, was that normal? And going on and going further, it turns out she did in fact have early onset of schizophrenia, and she did very well. So I think you'll learn much more about those kind of situations as we go on, but it really brings home the importance of this as a primary care topic. So a little housekeeping first. You have on your screen, and Beth, again, will tell you a little bit more about it. We do offer CME for this session. This session will be recorded and available on the MCPAP website, www.mcpap.com, and a copy of the PowerPoint slides and the recording will be available there. Our presenters will stop at questions at several points, but please put questions in the chat, and we may leave them at the end, or if they're particularly appropriate, we may ask the speaker to address them right in real time. If you have a question or comment, you can also type your questions into the question box, and we'll read those out at the end or unmute your line so you can. And finally, there'll be a brief survey at the end, and we really helps us determine what we might do for future presentations. And finally, today, just a reminder that many of you have probably gotten a request for a survey about MCPAP. It is open until the end of the week, so please do that if you haven't done that already. So today, we have three speakers, and they bring real expertise to this subject. Emily Gagan is a licensed clinical psychologist at the Brookline Community Mental Health Center. She's the director of the Massachusetts Psychosis Action and Triage Hub, MPATH, and is also a member of the team at the Center for Early Direction Assessment and Response to Risk, CEDAR. Natalia Nodiff is a young adult peer mentor at MPATH, where she works alongside the team with clients using her lived experience to provide insight and guidance. While most professionals understand psychosis from the outside, she knows what it is like to go through it firsthand. Natalia, I think you may be our first speaker with this kind of experience. We really welcome you. It's great to have you here. Tanya Trevet is an educator, family partner, and mental health advocate with a background in special education. She supports families navigating the complexities of mental health illness, particularly focusing on young adults and adolescents from facing serious illness during their college or high school years. So with that, Beth, you want to mention about the CME?
Sure. You can see on your screen, there is a phone number that you can text the code YERRUB, and it will give you some give you access to be able to claim your CME certificate. And I'll put that in the chat as well.
Thank you. So with that, Emily, all yours.
Great, thanks. Yeah, it's nice to have everyone here. Thanks for joining us. As John said, I have two of my colleagues here with me. You'll hear from them about their stories towards the end of the presentation, but I'm going to go through some basic information about early psychosis and symptoms and things like that. I'm going to try to get through a lot of material, so I might be going a little quick, but I will try to stop and excuse me, see if there are questions, and we'll try to leave time at the end as well. So I will share my slides. Excuse me. All right. So a couple things that I hope folks take away from today. The idea that psychosis is treatable, particularly when symptoms are recognized early. Psychosis is also a lot more common than I think sometimes folks know it to be. It's also on a continuum that we're all a part of, and I'll explain a little bit more what I mean by that in a moment. And when you're seeing young people, as John kind of shared that example, right? Like when you're working with them in this age range, you might be one of the people to be noticing some of these signs. But some of those symptoms or signs can be easy to dismiss or attribute to other things. So we'll talk about how that kind of all fits together and how we think about those things. So I do start with a case example. I'm going to read it now and then come back to it in a little bit, but it can be helpful to hold in mind and maybe go through, or if you think of a young person you might have worked with, that it brings to mind, could be helpful as well. Alexis is a 15-year-old who enjoys art, gymnastics, and spending time online. She's always struggled to connect with her peers, but that seems to have gotten worse recently. Alexis's mom also reports that she's always been close to her family, but that lately she's been isolating in her room instead of spending time with them. Alexis's mom has also reported that she's had some trouble with hygiene. Without encouragement from her mom, she'll go days without showering or changing her clothes. Over the past year, Alexis has been spending more and more time online, and she talks often about conspiracy theories she hears about on YouTube. For a recent assignment, Alexis wrote a long, detailed essay explaining how the world could be a computer simulation and is overly preoccupied with the possibility that this could be true. So like I said, we're going to come back to that in a bit, but helpful to keep in mind as we go through some of the this initial information. So when we say psychosis, that in itself is not a diagnosis, right? Psychosis is a set of symptoms that refers to when someone has some difficulty telling what's real from what's not, or where there's some loss of contact with what we would consider to be our consensus reality. And what we mean when we say that is that in a group of people, there's a kind of shared understanding of reality, kind of culturally agreed upon ideas about reality based on common experiences. And when someone experiences psychosis, there's some departure from that. And a person can experience psychosis in a number of different contexts. It could be directly related to substance use. It could be related to medical issues, maybe neurological issues like seizures, maybe sleep deprivation, and then maybe most familiar to folks, a mental health concern like schizophrenia, bipolar disorder, or depression. In terms of symptoms, we think about them in kind of very broadly two categories. So on the left, we have positive symptoms. When we say positive, we don't necessarily mean good, but we mean added on to a more typical or normative experience. So that includes delusions. So those are beliefs that are, again, inconsistent with our consensus reality. They can involve elements of paranoia, worrying that someone might be trying to harm you or plotting against you. Folks might experience hallucinations, might be hearing voices, seeing visions. But this, along with a lot of these symptoms, does exist on that continuum and can look a lot of different ways. And I'll talk more about that in a moment. And then disorganization. Folks can experience the thoughts in their own mind as being very jumbled, as being very disorganized. And that can result in disorganized communication, right? Trouble getting your point across or having other people understand what you're trying to say. And then also disorganized behavior. And that's really behaving very out of character, very off someone's baseline. Sometimes that can appear erratic. And then on the other side, just like positive means added on, negative means reduced, again, from a more typical or normative experience. So that could include reductions in emotions, both in the experience of emotions, so the range of emotions that someone might experience can be reduced, and then also in showing emotion. Folks can experience flat affect, right? So not knowing what someone's feeling just by looking at their face. Social interactions can be reduced, withdrawing from others, not wanting to do the things you used to enjoy, not talking as much with other people. And then also trouble generally with functioning. Folks can struggle with motivation, trouble with self-care, And then also cognitive issues, some new trouble with memory or attention. This slide lays out a lot of the same symptoms, just in a slightly different way, that I think can be helpful to keep in mind when you're talking about what you might notice day to day meeting with a young person. So they might have trouble with thinking. So that could include that trouble telling what's real from what's not, that element of suspiciousness or paranoia, but maybe also that trouble getting their point across. Folks might have trouble with or changes in perception. Again, hearing voices, seeing visions, might be hearing whispers, seeing shadows. Really what we're talking about here is new and puzzling changes in someone's perceptual abilities, hearing or seeing, right? Trouble with motivation. Again, as we said, trouble doing the things you need to do, like school or work, but also you can sometimes feel like your mind is going blank. And then those cognitive challenges, which again is new or significantly worsening. Difficulty with attention, processing speed, memory, organization, things like that. But as I've been referencing, all of this exists on a continuum. A lot of times I think folks think about psychosis as being present or absent, right? Someone has psychosis or they do not. And instead, I would really encourage you to think about it as existing on this continuum. And the way that we think about it varying along the continuum is in terms of how common the experience is, how much distress it might cause someone or how much it might get in the way, and then how certain the person is that what is they're experiencing is truly what's happening. And everyone is somewhere on this continuum, right? So if we look at that top example all the way to the left, someone might have the thought, I don't like my landlord. Unfortunately, probably a pretty common thought, right? Might depend on your landlord, but chances are it doesn't cause you a ton of distress though, right? It's not really getting in the way. You have that thought, but you're still doing all the things you need to do with your day. A little to the right, someone might have the thought, I'm not sure why, but I don't trust my landlord. Still probably a pretty common thought. It might cause you a little more distress to kind of have this vague sense that you can't trust this person. But the way that it's phrased, I'm not sure why. Meaning, if someone were to say to you, I actually know that guy. He's actually a good guy. Maybe he's a little strange, but he's a very nice person. And I think he's actually, he's not doing anything nefarious. And you could hear that information and say, yeah, you're right. I jumped to conclusions. Yeah, I mean, I guess he's a little strange, but you're right. He's always been a good landlord since I've lived here, and I think I judged too fast. So you could hear information to the contrary and change your mind. A little more to the right, someone might have the thought, I think my landlord might be trying to poison me. Not a common thought, but I think you can imagine if you had that thought in your mind, how much distress that would start to cause you, right? How much space that would start to take up in your mind, might change who you talk to, where you go. But at this point, I think my landlord might be trying to poison me. We're not 100% sure, but we do have a feeling that this might be going on. And then all the way to the right, someone might have the thought, my landlord poisoned the air and I'm sure he wants to kill me. Not a common thought, but I think you can imagine, again, if you had that thought, how much space that would probably take up all the space in your mind, right? Might change almost everything about who you talk to, where you go, what you do. And now at this point, there's not room for other information anymore, right? I'm sure he wants to kill me. We've reached that kind of 100% certainty. So you can apply this to a lot of the other experiences we were talking about, right? On the one end of hearing voices, folks might hear really distressing voices telling them to do things, etc. And on the other end, I know I've had the experience of being in a room with other people and you thought you heard your name being called. Then you turn around, no one said anything. And you say to yourself, like, gosh, I could have sworn someone just said something, right? But, then you kind of just move on, just a little out of the ordinary experience. Similarly, folks might have visual hallucinations. Might see visions, figures, can be very scary. And maybe on the other end, you've been at home and you thought you saw your dog walk by out of the corner of your eye. And then you turn around, your dog's actually in the other room. And again, you say to yourself, I could have sworn, right? He just walked by. But again, you say, okay, must have been a shadow, must have been something else. So I think I really encourage folks to think about it in this way, both in terms of identifying lower levels of risk for psychosis that we'll talk more about in a moment, but also in terms of how to talk to a young person about their experiences. And instead of thinking about it as perhaps presumably something you have not experienced, and they have, so a very separate thing, but more so being able to put yourself in that person's shoes a bit more, right? And be able to talk a little more about what that might be like. Because that can also really work towards engaging that person and being willing to share with you more about what might be going on. Especially for young people who feel like they might be the only ones having this kind of experience, right? In terms of how common, this is in particular how common the diagnosis of psychotic disorders is. Around 3% of folks will be diagnosed with a psychotic disorder. That's around 1% with schizophrenia, 1.5% bipolar, another 0.5% with things like substance-induced psychosis. But importantly, the average age of onset is right in that late teens to early 20s range. That graph on the right is for specifically the diagnosis of schizophrenia. That highest point, right, is in that late teens to early 20s range. And in Massachusetts, there's over 1,000 new episodes of psychosis each year. And what we also know from research is that folks see their primary care doctors or pediatricians much more in the, I think the research was 10 months leading up to a first episode of psychosis, right? And so all the more reason that we want folks to be able to know the signs and identify these things early on, because what research also tells us is that it's early intervention is that what can help folks get back on track. And I'll talk more also about that in a moment. This is representative of kids ages 11 to 18. Around just an example of why this might be more common than folks know it to be. So around 17% will have what we call a psychotic-like experience. So those are those things maybe in like the middle-ish of that continuum, right? Maybe an experience that happens once, but then never happens again. Around 7.5% or so of folks meet criteria for what we call clinical high risk for psychosis. Again, we'll come back to that, but it's really this kind of constellation of symptoms, changes that we're noticing that are suggesting to us that someone might be at higher risk of developing psychosis in the future. And then, as we said, around 3% go on to develop a psychotic disorder. So again, more common than I think sometimes folks know it to be, and that kind of perspective can go a long way when you're talking to a young person who might feel like they're the only ones having this experience, right? As I said at the beginning, recovery is very possible, and as early intervention is really the goal. And in this context, what we mean when we say early intervention is reducing what's called the duration of untreated psychosis, or the DUP. And what that is the time between when someone first experiences symptoms and when someone first receives treatment. And the shorter that time frame is, the better someone's long-term outcomes are. Again, in that example that John shared, right? Like that 14-year-old was identified quite early and went on to do quite well. So that's really what our goal is in terms of identifying folks early on. And folks might be familiar, but there are a number of clinics in Massachusetts that specialize in working with adolescents and young adults who've recently experienced psychosis. And I'll talk a little more towards the end about how MCPAP can be a resource to helping connect folks to those clinics. This is an example of why we are aiming for early intervention, right? It also explains a little bit what we mean when we say risk for psychosis versus going on to develop psychosis. So the top blue and green lines are our goal in terms of catching folks early on, right? This represents 2 folks who were identified early in that warning sign, early stages phase, and received treatment specific to those symptoms. The blue line person went on to not develop a psychotic disorder. They treated the symptoms that were happening, that were giving us this kind of risk signal, and they went on to do very well and did not develop psychosis. The green line person also was identified early on and did go on to develop a psychotic disorder, but due to that early intervention, also did quite well, right, long term. The red line is what we're trying to avoid. And that means what we're trying to avoid is how long symptoms, signs of risk, symptoms have gone on before someone has received any treatment or any support, because that can negatively impact that long-term trajectory, right? The website at the bottom that folks might already be familiar with, psychosisscreening.org. It was developed in concert with MCPAP, as well as folks at Beth Israel. It is specifically designed for a primary care or pediatric provider audience. It has a lot of great screening tools, decision-making flow charts, some of which we'll talk about today, but I do want to point that out to folks that that's a great resource to have on hand, kind of just day to day. And again, just to, really hit home the point, right? Like we're trying to aim for early intervention. The average adolescent can experience psychosis for like a year and a half before they receive treatment. But the World Health Organization recommends that DUP, that duration of untreated psychosis, really be no longer than 90 days for optimal outcomes, right? So that's a big difference. So the more we can be identifying folks early on and offering support, the better. And some of this can happen in crisis settings, right? Emergency rooms, inpatient units where folks get diagnosed. It doesn't mean it's the end of the road for folks, right? But those can be scary experiences. And the more that we can help folks avoid those situations, if we can, the better. And I keep talking about these kind of negative long-term outcomes. Well, what does that mean? Folks can struggle with functioning, meaning generally functioning in the community, right? Finding your place in the community, doing what you want to be doing with your life. Trouble with cognition, increased risk of suicide, and then also trouble socially, finding meaningful relationships, again, finding that community. And as we've been saying, right, when you work with young people in this age range, really you can be some of the first folks to be noticing some of these warning signs. So coming back to the case example, I wonder if folks have any thoughts, things you'd want to ask more about, that you stick out to you. Also, any other questions at this point, happy to answer as well. I know we've been moving at a fast pace. But yeah, any thoughts? Feel free to put them in the chat or just unmute, whatever.
Yeah, I'm looking at the chat and don't see any questions or thoughts that people are sharing.
Okay. Yeah. One thing I always...
John,
oh,
are
go
you
ahead.
saying something? I see your lips moving.
So, Emily, I'd like to know, is this person used any substances?
Great question. Yep. 100%. Maybe one of the first questions to ask, really, right? Like to find out if there's any potential involvement there that we should be considering. Yep. It would be nice to know about family history, right? To know if there's any family history of serious mental illness or psychosis in particular.
The neurologic illnesses or diagnoses?
Yep, absolutely. And as you know, folks here are probably the most aware of the folks that I often talk to, but the younger that we're talking about, the more we want to be ruling out medical causes of these symptoms, right? So wanting to take into consideration, as you said, any other neurologic possibilities or other medical conditions that might explain symptoms.
Another thing to wonder about is mood disorder symptoms. Yep. Yeah.
100%. Especially because I think, and this is often the reaction to this example, is that top paragraph could describe a million different things, right? That top paragraph could be accounted for by mood related things, anxiety, adolescence, right? Like there could be a lot of things. And then we're looking at that second paragraph that is telling us maybe a little bit more about what might be going on or what we would want to be considering or monitoring or things like that. The way that I've described it, and I'll probably say this again, is as you're encountering a young person and you might be doing what you just said, Barry, like what is it? Mood? Is there anxiety? Is there trauma? Is there substance use? Like John said, can we add risk for psychosis just to the list of what we are keeping in mind, right? Because now the assumption is not that folks are now able to diagnose psychosis, right away. But what we're trying to do is identify and monitor some of these symptoms and keep an eye on them, right? And sometimes the answer is we're just monitoring, we're not sure, but we're wanting to not miss signs that are telling us that there might be more going on. The other thing that I think I often try to point out in here is that we're thinking about what is a change from baseline. So as it's described, she has always struggled to connect with peers. That's the baseline, right? And she's not great socially. That's okay. What we're looking for then is there's a change from it that seems to have gotten worse recently. So that's what we're trying to identify as another sign that there might be more going on, but not trying to then like pathologize something that is someone's baseline and is not of concern. Any other thoughts or questions before I keep moving? Okay. So like we've been talking about, right? When someone has what we would consider kind of a clinically significant episode of psychosis, that usually means there's a pretty significant disruption in someone's functioning, right? Someone might have to go to the hospital. But what we're trying to keep an eye out for and also identify is this idea of clinical high risk for psychosis. And as I said earlier, it's this kind of constellation of symptoms, changes in mood, in thinking, and also perceptions, right? That hearing and seeing piece that are suggesting to us that someone might be at higher risk. And we're also taking into account family history. And the reason for this is that folks that go on to develop psychosis generally have had other mental health concerns earlier on in life. And research has told us that we can reliably identify folks that meet this criteria of high risk. However, importantly, of the folks that meet that criteria, only around 10 to 25% go on to develop a psychotic disorder. So what we're identifying in this group of folks that meet that criteria are folks having mental health challenges due to a number of different things. The idea being that maybe at this point, all we're doing is monitoring symptoms, but we're wanting to notice and keep an eye on these things so that we can know if they are escalating, if someone needs more support, if it seems to be developing into a psychotic episode. These are the signs that we're talking about, really. And some of these were in that case example, right? The top 4, you could say, would be due to so many things. But we're looking for that change, a lot of change from baseline, change in work or school, a new or significantly worsening trouble with concentration or attention, trouble with self-care, maybe some withdrawing socially. And then what we're also looking for are those things in darker yellow, right? These unusual or intense ideas, that element of suspiciousness or paranoia, perceptual changes, which can sometimes even look like new sensitivity to light or sound that someone did not have before. A great way to ask about it is to ask if you've ever felt like your mind is playing tricks on you. And then also taking into account family history. In terms of screening, there are a number of screening tools. Several are available at that website, psychosisscreening.org. This is an example of one. They can be very helpful, but I have a large caveat. I think when people use screening tools, they use them, they get a score, and they decide that that must mean this thing. These kinds of questions, folks say yes to for many reasons. So I don't want to get too stuck on just that yes or no answer. If there's a possibility, I know folks always have limited time, and I very much understand that. And if there's a way to use it to ask a couple more questions about what might be going on, right? Or maybe asking behavioral health colleagues to follow up on some of these questions. Because what we want to do is ask these as an open-ended question to find out more information rather than just landing on that yes or no and kind of going with that as our answer. And people can say yes to these for many reasons, which I'll touch on in just a moment. Research has also told us that these are probably 2 of the best ones to use as a screener. Do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt like someone was playing with your mind? They have the best sensitivity and specificity. But again, I still would want to know a little more once I get a yes to those, right? Because again, people can still say yes to them for a number of different reasons. So I'm not going to spend a ton of time on this because we're pressed for time, but this is touching on a little bit of all the different other reasons someone might describe symptoms that sound like psychosis, right? In terms of concentration difficulties, for example, right? What we're looking for as a sign of risk is new or significantly worsening difficulty with concentrating. If we see it as part of a trajectory of a kid that maybe had some trouble earlier on, now has gotten to high school, it's gotten harder, the work has gotten harder, they're having more trouble, right? That's a pretty typical trajectory. This is what we're looking for. What we're looking for here is more very significantly worsening difficulty. Trauma, kids that have experienced trauma, especially the younger that you go, can report hearing voices, seeing things, really intense paranoia. And still, the best explanation might be PTSD, right? So just because someone is reporting some of these perceptual experiences does not immediately mean someone has a psychotic disorder, right? We want to take into account that other piece that we might know about in terms of trauma. Autism, kids with autism can be concrete, can describe internal experiences in a way that sounds almost as if they're hearing a voice. And a quick example I'll give is a kid that has a black and white sense of right and wrong. I'm a good person, there are bad people in the world. That's how I understand it. And then they have a thought they want to punch their dad in the face because they're making them mad, right? That doesn't fit with their understanding of themselves as a good person. So they might understand that as like, I guess that's a voice telling me to do that because I would never do that, right? And so really wanting to, again, not stick with those yes or no questions if there's more to know about what the context is for how someone might be describing that. Substance use, in terms of how to figure out if it's substance induced, is the unsatisfying answer is time. We have to know when someone started using, when they stopped using, what happens when they use again, how do the symptoms fit into that timeline? What we do know is cannabis can bring about psychosis, right? Especially in someone that was at risk. And cannabis can make symptoms of psychosis worse. And then also not wanting to pathologize things that are typical and common and normative in someone's culture, ethnicity, religion, family, but hoping to not miss signs that there might be more going on. And I'll talk through an example of that in particular in just a moment. Also, all of these could be their own talk, which is why they are. There's a link at the bottom that has a bunch of talks that we've had people come in and do just on one of these, right? So just psychosis and OCD, just psychosis and autism, things like that. So in everyone's ample free time, you can take a look through some of those as well, but I do think they are a great resource. Importantly,
Hey, Emily.
oh yeah.
Yeah, just a quick question. The last bullet there, I used to, focus a lot about, sort of whether, beliefs are, part of the families, or the community's, culture. And I've sort of run into some limits, in terms of applying that, principle. I think particularly because adolescence, particularly at this, this age, there's kind of like an explosion in sort of, new ideas, and abstract thinking is emerging. And so when that starts happening, in addition to like the rebelliousness, and the needs for independence, sometimes like belief systems can be embraced that are
Yeah.
they're discovered from peers or from the culture at large, but they don't belong to the family,
True.
and they seem really uncharacteristic. And so I've seen a number of patients where they weren't psychotic, but they had sort of become really taken, with, sort of ideas that were not, kind of things that they were brought up to believe. So it's just another, little wrinkle.
Yeah. No, I think
Are
that's
you saying, Barry, that our government has some of these same symptoms?
I wasn't, John, but it could be said, I suppose. Yeah.
Yeah, no, that's a great point. And I think that comes up a lot, especially more with social media, right, too. And I think what I am always trying to look for is, are we seeing other difficulty in other areas, right? So someone has this new set of beliefs or, ways of understanding the world, but everything else is still going well, right? They're still doing well in school. They're still like connecting with friends, all these things. That's a different presentation than someone who's having a lot of these new beliefs and things, and we're seeing other decline or other difficulty, because then that maybe is a suggestion that there's more going on. But I think it's a great point. It's super complex and even more so these days, thanks to maybe our government also, but yeah, definitely. Great point. Importantly, symptoms of psychosis by themselves do not necessarily mean that there's a cause for concern for safety. I think sometimes folks can equate psychosis with risk for harm or things like that. However, I think folks are also aware there are many people in the community all the time experiencing symptoms of psychosis, and that does not mean they need to be in a hospital, right? I know when we're talking about younger folks, like we want to be, cautious and thoughtful and making sure that if there's other like more pressing medical concerns that we're addressing those. And someone, I've encountered some clinicians who tell me like, yeah, my client told me they were hearing voices, so of course I sent them right to the hospital. Slow down. There's a lot of steps to figure out, right? And at times, yes, absolutely, we might need a higher level of care. But wanting to be thoughtful, especially what is always in my mind is what's going to make this young person want to tell me more things later on. And if someone tells me these things and I immediately say like, you got to get out of here, you got to go to the hospital, maybe a little less likely, right? So wanting to be thoughtful about that kind of thing. In terms of how to talk to a young person who might share some of these beliefs with you, it can feel like we want to tell people why that's not true, because that might make them feel better, right? Well, don't worry that the world is a computer simulation, because it's actually not. Here's the evidence. And if you think about something you believe really strongly, and someone just tried to sit you down and tell you why you're wrong, might not feel great, right? Despite best of intentions, it can feel invalidating. So what I'm always wanting to do is be curious, ask more questions, also listen for the emotions that are underneath, right? In that case example where Alexis does believe the world's a computer simulation, what I would probably want to say is like, gosh, that sounds really confusing. I can imagine you feel really alone. Can you tell me more about it, right? Because folks are also probably met with, if they're telling friends and family about it, they are probably met with, what are you talking about? That doesn't make any sense. No, just stop thinking about it. So if you as providers can be the person that wants to know a bit more and not just is immediately trying to kind of, tell people while they're wrong, that can go a long way. These are some of the screening questions. They're on those screening tools, so I won't spend much time on this. As I mentioned, some of the best ones is that question about feeling like your mind is playing tricks on you, but also that confusion about what's real and what's not, control of your own thoughts or ideas, those perceptual changes, right? Sensitivity to light and sound. And then also that cognitive piece. You have trouble getting your point across. Are other people confused when you're trying to explain something, right? But then folks say yes, and then you say, oh no, what do I do now? Well, ask more questions. What is it like? How does it impact them? Has it changed over time? How often does it happen? Really what I'm trying to find out is it getting in the way? Is it causing any distress? And has it changed, right? Because the most important way that this comes into play is cultural beliefs, like we were talking about earlier, right? So a quick example might be that a young person tells you that they think their house is inhabited by spirits. You ask the family more and you find out, of course, we all believe that. Absolutely. The people that have come before us are still with us. We talk about it every day. Sometimes we even joke about it. Like it's just part of our everyday. And no one is worried or upset or bothered by this in any way. One example. Similar but different example might be that you hear that from the young person, and then you ask the family and you find out, yes, of course, we all believe that. We always have. But actually, in the last few months, now our son or daughter, it's all they can talk about. And now they won't come out of their room because now they're worried their spirits and the rest of the house that are going to harm them somehow. And we missed a doctor's appointment the other day because they wouldn't leave. And everyone in the family is so confused by this because no one has ever been bothered, right? Two very different examples. The former has not changed, is not getting in the way, and is not causing any distress. The latter, all of the above, right? So really wanting to find that middle ground of not over pathologizing things that maybe we're unfamiliar with, but also not missing signs or attributing everything to someone's culture, religion, etc., if there are signs that are telling us there's something going on. Regardless, how do we hope you respond if a young person shares this with you, right? Well, with hope and optimism. Gosh, thank you so much for telling me about this. This is actually a lot more common than you probably think it is. And if you would like support with it, let's talk about how I can, point you in the right direction. In terms of how to talk to families, this is a guide with a long acronym that was developed by colleagues of ours at Beth Israel. There's a link at the bottom to the citation, but I think it's a nice overview of how you might approach these conversations when you talk to a family about maybe having some concern. Some of these I think are common sense, but a couple that always stick out to me are taking a normalizing and non-stigmatizing approach, right? Normalizing this, as you know, is a type of human experience, addressing the stigma that families may have about what psychosis means. Taking a person-centered perspective, of course, right? Respecting people's autonomy and preferences and values while making sure they have the information they need. And then empathizing and empowering. Empathizing with what might be strong reactions, maybe based on stigma, right? About what it means if their child might have psychosis. And then also empowering them to say, but here's what we know about treatment, about support, early intervention, all of these things. The clinics that I described briefly, early psychosis clinics, use a model of care called coordinated specialty care. The young person and family receive all of their outpatient mental health services from one team. So individual therapy, meds, family therapy, peer support, work and school support. There are a few clinics that specialize in clinical high risk for psychosis. And then there are several that are first episode or early psychosis clinics. However, that can feel confusing to figure out who should go where and when. So what I would hope you do is call us at MPAP. So we're a free resource. We are statewide. We are based at the Brookline Center, but we are statewide. And we are trying to be a front door to those clinics and help point people in the right direction and then offer support along the way. This is our team. So for when we hear from young people and families, we're not doing treatment ourselves at Empath. But we are offering education, resources, consultation, and we have a big piece of support we can offer is Natalia, who is our young adult peer mentor, who you'll hear from in a moment, who can meet with young people directly. And then we have family partners who can meet with families to talk about supporting their own young person with psychosis. Excuse me. And then we can help point folks towards, if it makes sense, one of those clinics. All the clinics have different criteria. It can feel confusing to navigate. So that's the kind of thing, the information we try to hold and point people in that direction. We do also a lot of consultation with providers. So we meet with providers to talk about kids that they're working with, where there's some question of, this, they reported these things. I don't know what to make of it. Might this be psychosis? Might this be something else? I'm not sure what a next step should be. The reason that we do this is we're trying to help people provide psychosis-informed care, right? When you do trauma-informed care, the expectation is you don't have to be an expert in trauma to do it, right? But you understand how trauma can impact people and that it does impact people. So in a kind of similar way, we try to think about how we can help people feel like they have confidence, information, resources to talk about psychosis without feeling like, oh, I don't know about this. This is for an expert. I have to send this, to someone else. If you reach out to us, we would do a quick phone call with our coordinator to just get some information about how we can help. And then we can do a lot of different things. We can schedule that consultation on Zoom, usually quite quickly. We can then reach out directly to the family or to the young person. We just always want to check with you first to make sure they're expecting our call, right? We can help with a referral to one of those clinics, clinical high risk or first episode psychosis. And we can also help connect to community resources. I will put the contact information in the chat also in just one moment. And if folks ever would want us to do a presentation for your staff at your office, we'd be happy to do that. We can do them virtually or in person. I will put my email address in the chat as well, but I can do the same sort of training for staff at your individual offices. So please feel free. These are some resources you can take a look at when you have the slides. But now we're going to stop the recording, but we are going to turn it. I'm going to turn it over to Tanya, who's going to share with you her experiences. I don't know if